Good afternoon. As someone who is affected by Alzheimer's, I know that the time is now. Alzheimer's will not and does not wait. The facts and figures are staggering. 5 million people are currently living with Alzheimer's disease, and 15.4 million people are caring for people afflicted with this disease. Currently, 1 in 3 geriatric deaths are related to Alzheimer's. And the disease's impact will continue to grow as baby boomers age. And if we look around this room, most of us are baby boomers. As dire and as hopeless as this sounds, all is not lost. As you will hear from Linda Mitchell, the CEO and Executive Director of the Colorado chapter of the Alzheimer's Association, there is support for people who have the disease and are caring for loved ones with Alzheimer's. I became involved with the Alzheimer's Association when my father's initial diagnosis of Alzheimer's in 2006. Linda listened to me and provided my family and me with solutions when we were overwhelmed with my father's disturbing diagnosis. She has an MSW from the University of Denver and has been involved with leadership in the nonprofit sector for over 20 years. She has created one of the most vibrant association chapters comprised of 7 offices here in Colorado that served over 29,000 people last year. Her co-presenter today is Dr. Huntington Potter, a professor of neurology and director of Alzheimer's disease research at the University of Colorado School of Medicine and the Linda Cernick Institute for Down Syndrome. Dr. Potter has a PhD in biochemistry and molecular biology from Harvard and also served as the faculty at Harvard for 13 years. He created the first regional National Institution on Aging Alzheimer's Disease Research Center in Tampa, Florida, before coming to CU in July 2012. It is his hope to establish the first NIA Alzheimer's Disease Research Center between St. Louis and San Francisco, here in Colorado. Please welcome these incredible visionaries in the fight against this disease.
Thank you, Melinda. I've had the pleasure of knowing Melinda and her mother and her father for quite a few years, and it's always good for me to hear that we made a difference in a family's journey with Alzheimer's. How many of you have had a family experience or a close friend with Alzheimer's at this point? Oh my goodness, yes. When you look around the room and see 2/3 of you have been down this road, you know probably a lot about what the Alzheimer's Association stands for. Alzheimer's disease has been called the defining disease of the baby boom generation. We know that without significant progress in research, very soon, at least 10 million baby boomers will develop the disease in their lifetime and spend their retirement years living with this. And many, many more will serve as their caregivers. Alzheimer's is a fatal disease of the brain. There are no survivors. It is the most common form of dementia, and I was talking with some people before lunch about that. Dementia is often still given as a diagnosis to an individual and their family, but Alzheimer's really accounts for about 70% of all forms of dementia. There's no treatment yet to slow the progression of the disease, and there's no cure. But there is a lot of research going on, and that's one of our most important reasons to hope. Currently, 5 million people in this country are living with Alzheimer's and 72,000 in our state alone. Alzheimer's disease is now the most costly disease in the country, more than heart disease or even cancer. And all of these numbers are rising, including the costs of the disease, because our society is aging, and age is the greatest risk factor for Alzheimer's. The Alzheimer's Association of Colorado has been here since 1980 to stand by families who have to live with this disease today. We've grown over those years to be a statewide organization. Our headquarters is here in Denver, and we have 6 regional offices around the state. So we have 42 professional staff members working with families across Colorado, but the real news is that we have over 1,100 active volunteers, and that's how so much of our work gets done. We have an annual budget of $4.5 million. We're a private nonprofit organization. And our services to families really span the range of the disease from early stage, right after that difficult diagnosis, clear through the end of life. So we have a 24-hour, 7-day-a-week helpline to take calls from individuals themselves who might be concerned about changes in their own memory or other functions, and they kind of want to know what they should do, what's the next step, all the way through the difficult caregiving calls that families have over the many years that they deal with this disease. And it's important that we're there after hours, on weekends, holidays, to answer those questions and provide the kind of on-the-spot support that families often need. So that 24-hour, 7-day-a-week helpline is a lifeline for many families. We have over 90 support groups meeting every month across the state. We provide care consultation and care planning for families. Again, all of these services are at no cost. And it's important for families to be able to come together with one of our professional staff members, sit down and get everybody on the same page with their understanding of what this disease is, where it's probably headed, what the most immediate needs of the family are right now, today, and then to look a bit down the road and see what kind of help they might need, what kind of resources, what we have at the Alzheimer's Association that would be most appropriate for them at that particular time. And then to continue that kind of work with families over the many years of the disease, because on average, this lasts from 8 to 12 years. But I did talk with someone today who mentioned knowing of a family that dealt with it for over 25 years, and that's not unheard of. So people need different things at different stages. We also have an extensive set of services and opportunities for individuals in the early stage of the disease themselves. They're the ones that have this diagnosis. They're living with a very difficult condition. Many times they want information, they want education about it, they want to be involved in their own planning with their families for the future, and they want to connect with others who are also living with this diagnosis. So in addition to all of that education and support that we provide to them and their families, we also have a rich array now of social opportunities and volunteer opportunities to keep them engaged and connected just as long as possible. So as Melinda mentioned, we're one of the 70 chapters of the National Alzheimer's Association across the country. And all of us, as part of the association, are providing these very valuable, critical services to families, but we're also advocating for increased funding for Alzheimer's disease research. The Alzheimer's Association serves as the largest private funder of Alzheimer's research in the country today. But what we really need is for the federal government to step up to a much higher level of research funding for Alzheimer's. So I'd like to ask each of you to become a champion in the community, in your networks, with your colleagues and friends at your churches, to let people know, first of all, that the Alzheimer's Association is here for them. Too many people still don't know that we even exist. We do not have a huge advertising budget. We depend on people like you to be our champions, our ambassadors, and carry that message that no family should have to live with Alzheimer's disease alone. We have help for them from the early stage all through the caregiving years to the end of life, and those services are available at no cost to families throughout Colorado. So if you'll help us with that, I would greatly appreciate it. There is some information on your table about the 10 warning signs of Alzheimer's disease, and I would ask that you take that and share it with someone that you know that might be concerned about a family member or a friend. And now it's my pleasure to turn the program over to Dr. Huntington Potter, who's going to share some really exciting news about research and treatment going on right here in Colorado.
Thank you, Linda, very much, and thank you all for coming to learn about Alzheimer's disease, and I hope by the end to be gratified and inspired that we are on the right track to trying to develop new treatments that may work much better than what you have available now. I think that the Alzheimer's Association President Linda Mitchell has put the problem to you very well, and I won't repeat that. But I will say that over the last 20 or 30 years, essentially the Alzheimer's Association has been feverishly bailing a leaking boat. And what we've got to do now is to begin to fix that leak. We still need bailers. Please volunteer and help in any way you can. And also please help the people who are trying to fix the leak, which are the researchers that are working for you to try to solve this problem, hopefully permanently. So what I'm going to leave you with today is a sense of where we are and our knowledge about Alzheimer's disease and where we're going with respect to new treatments. So basically, Alzheimer's disease comes in two forms. Sporadic, which most of you are pretty aware of. Basically, 50% of people over age 85 have Alzheimer's disease. That includes, I hope, most of the people in this room who will live to be 85, and the other half or more will be caregivers. But there's also a very small percentage of people who have genetic Alzheimer's disease, and that turns out to be very bad for those families, but very good for research because we can understand much more about the disease thanks to the fact that in these families, a single mutation in a single gene causes Alzheimer's disease. And since you carry two genes for two copies for every gene, basically if you have one of this kind of Alzheimer's disease, half your children will have Alzheimer's disease at the same age. That age can be in the 50s, 40s, 30s, even late 20s. Very rare, but very helpful. The third group, which I study particularly, is a group of people who have Down syndrome. And we'll talk a little bit more about that as the day goes on. But basically, people with Down syndrome all get the pathology of Alzheimer's disease in their brains, and at least half develop dementia at a very early age. And that also gives us insight into what is causing the problem. So what is Alzheimer's disease? Well, as Linda indicated, it's the most common form of dementia, the cause of dementia in the elderly. And what Alzheimer himself saw when he looked at a person with Alzheimer's disease, later named, not by him, by the head of his institute, is a shrunken brain, which then when he used his microscope to look at it with special stains, he could see the characteristic lesions of Alzheimer's disease. These are the plaques and the tangles, which occur in the millions in the areas of the brain involved in cognition. Now, it could have been that these pathological lesions were just the correlate of the disease. They didn't cause the disease, they were an effect of the disease. But it turns out that we now know that they're an important part of the pathogenic pathway. And that was started by Glenner and Wong in 1984 when they were able to chemically analyze, oh, I'm pushing too many buttons at once, big fingers, and found out that this amyloid deposit at the beginning and middle of these amyloid plaques starts with a peptide called the A-beta peptide shown here. And with that discovery really opened up the biochemistry and the genetics of Alzheimer's disease. So what did that allow us to do? Well, many people contribute to this, and we now understand that essentially Alzheimer's disease starts with a big protein called the amyloid precursor protein, and in it is embedded this A-beta peptide, which is cleaved out in Alzheimer's disease to make this A-beta peptide. It has a spontaneous tendency to make fibers, and those fibers then aggregate in the brain to make lots of little Brillo pads that are very toxic to the nerve cells. So with this kind of pathway, we know a lot more about the disease process, and we can begin to develop treatments, and many are being developed now with gamma secretase inhibitors, beta secretase inhibitors, inhibitors of the filaments, and some of them are in clinical trials now. We just don't know what the answer is as to whether they're going to be helpful. But so far, no new drug has come out of this pathway, but we're very hopeful that some will. Now, I mentioned that people with Down syndrome all develop Alzheimer's disease, and that's true. So there's something connected between these two groups of people. And we proposed that, as you know, people with Down syndrome have 3 copies of chromosome number 21. They have 2 copies of every other chromosome. We all have 2 copies of chromosome 21, but they have 3 copies of chromosome 21. And that's very interesting because it turns out that the amyloid precursor protein gene is on chromosome 21. So instead of having 2 copies, they have 3 copies. That means they make more of the precursor and more of the peptide, and that's why they get Alzheimer's disease. So what we proposed is maybe there's a bigger connection there than we think. So for instance, in this family, which is a little hard to see, basically 50% of the children of a person with Alzheimer's disease get Alzheimer's disease because they have one of those mutations. And that mutation in this particular family is in the amyloid precursor protein gene. So that means that they don't have to have 3 copies. All they have to have is a mutation in that gene, and they get inherited Alzheimer's disease. So that reinforces how important this gene and this protein is. So what we did was to say maybe what happens in Alzheimer's disease is that over the course of your life, you develop mistakes in your cells that look like Down syndrome. That is to say, the cells make mistakes when they divide their chromosomes, and so some cells develop 3 copies of chromosome 21 instead of 2. And so we can count chromosomes either this way, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, or this way with a little target probe that allows you to just count 1 or 2 chromosome 21s. Or if you use a different color, you can see chromosome 12. And what we did was to count chromosomes in the skin cells of people with Alzheimer's disease and find that, yes, 5% of the cells have trisomy 21, whether they're familial AD or sporadic AD. This has been then repeated by a number of other labs, and here's some very interesting work from Europe where they counted the nerve cells in the brains of people with Alzheimer's disease and found that 10% of the nerve cells are trisomy 21. So when you have Alzheimer's disease, you have a kind of developed Down syndrome. And there are other chromosomes that are abnormal as well. That's very interesting because it tells us that we should look at the cell division and find out what's wrong in Alzheimer's disease, and we're beginning to do that now. So for instance, if you take that amyloid peptide that I talked about and add it to cells in culture, you find that it causes problems with chromosomes. This is a daughter cell, this is a daughter cell. They used to have a mother cell, and when that mother cell divided in the presence of the A-beta peptide, the cell made a mistake, and this cell, instead of getting 2 copies of chromosome 21 and 2 copies of chromosome 12, got 3 of chromosome 21 and 2 of 12, and its other sister cell got 3 copies of chromosome 12 and only 1 copy of chromosome 21. So we know the mechanism, we know the target, and we're beginning to develop new drugs for this genetic problem, and it probably is a problem that affects all kinds of Alzheimer's disease. Now, the other interesting thing about this is that this is looking at the genetics of Alzheimer's disease. But Alzheimer's is probably only about 70% genetic for many different possible reasons. But that means it's about 30% environmental. So we can't do much about our genes yet, but we can do a lot about our environment. So we and others are also looking at environment, and it turns out that if you, I've skipped this slide here, hold on a second. There it is. Okay, I'm going to skip slides and come back to what I was talking about before. So environment is important also. It turns out that the normal mouse cage like this, the mouse can develop Alzheimer's disease, but if we put them in the club med cage, which is shown over here, then the mouse does much better. It doesn't get Alzheimer's disease, even though it has the mutation that caused the familial Alzheimer's disease in the humans. So this mouse ought to get Alzheimer's disease, but because it has running wheels to exercise, it has lots of toys to play with, other mice to talk to, then this mouse doesn't get Alzheimer's disease. And all of the human evidence so far suggests that exercise and cognitive stimulation are helpful for reducing the risk of Alzheimer's disease, and I'm sure that's why we're meeting in the Denver Athletic Club. And coming to meetings like Rotary stimulates your brain, and that's also good for reducing your risk for Alzheimer's disease. So you have something in your own hands, and on your table is coffee, and it turns out that coffee and caffeine also reduces the risk of Alzheimer's disease. We're trying to find out why now, so drink up. Okay, so now we were looking at a group of people who always get Alzheimer's disease, that's people with Down syndrome, but we also looked at people who almost never get Alzheimer's disease, and that turns out to be people with rheumatoid arthritis. And as you know, people with rheumatoid arthritis usually take a lot of drugs for inflammation and pain. So the hypothesis was that maybe these drugs are preventing Alzheimer's disease, and some very big, very expensive trials were carried out, and they don't work. In fact, some people with Alzheimer's disease get worse when they take these anti-inflammatory drugs. So we thought of a different approach, which was maybe there's something inherent about rheumatoid arthritis that was protecting them. And so my student, Tim Boyd, went into the laboratory, and he asked, what is it that is released during rheumatoid arthritis that might protect them? And we made a big, long list, and I'm going to make a long story short, GM-CSF, which stands for granulocyte macrophage colony stimulating factor, and at the end we'll ask you what that means. This molecule is released during rheumatoid arthritis, and if we inject it into one part of a mouse brain with amyloid deposits, half of them go away with one injection in 1 week. So that was an amazing result, and interestingly enough, this molecule can be injected subcutaneously as well, and the mice get better in terms of their amyloid deposits, just like this, but they also manage to get around a water maze like this much better, in fact, equally well as a normal mouse. So basically this is water maze allows the mouse to get out of the water by getting on this little glass platform, okay? These mice are incredibly valuable to us. We never let them suffer because it costs more for them to be in our mouse house per gram of mouse than it costs to pay my salary per gram of Hunt Potter. So we're very careful with these mice. We don't let them get hurt, but they help us because when they get Alzheimer's disease, they can't find this platform. And if they live in that Club Med cage, they can find the platform. And if they get GM-CSF, they can find the platform. Now, the interesting thing about that is that GM-CSF is already an FDA-approved drug for bone marrow transplant patients. Totally safe. And that means that we can begin a clinical trial, which we have just gotten permission to start here in Denver. Basic ideas, GM-CSF, or leukeine is the commercial name, would help the bone marrow make various kinds of cells which could get into the brain, get rid of the amyloid, improve the connection between neurons, even make the neurons live longer, and improve blood flow and help Alzheimer's disease. We don't know whether it's going to work, but we can only do that with experiment, and we've just started the first initial pilot experiment here in Denver. Okay, so basically we're doing this on a shoestring. You know, the University of Colorado has put $2 million into this project and other projects that we're doing, and the Center for Alzheimer's Disease at the university. But we've got 200,000 patients in the Colorado area. The cost here is about $7 billion annually. We've got a crisis. And so the standard way to solve a crisis is to build a program for centers, and that's what's happened at the universities at all over the East Coast and the West Coast, but there's no national Alzheimer's center, as Linda indicated, in this region at all, and we are building one here in Denver. which we very much need. We've gotten started. Jonathan Woodcock is the clinic director for the Memory and Dementia Clinic, along with Chris Philly, and we've started our Alzheimer trial with Lukine, and the whole idea is to try to build a national Alzheimer's center right here in Denver. If you want to help, you can tell your friends about it. If they've got $1 billion, they can contribute, but the most important thing is to write your legislator and tell them that this is a statewide, nationwide, worldwide crisis, and we need their help as well as yours. So we hope to find a cure at the Colorado University Results Center, so to speak, and try to reduce this risk. So thank you very much for your attention. I will answer questions. Linda will answer questions, and we'll stay afterwards also in case you have personal questions. Thank you very, very much.
After hearing your presentation, should we all go get blood tested and find out whether we have that gene?
I'm sorry, I didn't catch most of that.
Should we all be tested, or our genes?
No. It's not worth it because the genes that cause inherited Alzheimer's disease are extremely, extremely rare. And average people like you and me, there is a gene which is a risk factor for Alzheimer's disease called apolipoprotein E, but it's only a risk factor. I don't know my ApoE status, and I wouldn't recommend people go out and ask for it unless they have cognitive problems already, and then their physician may decide to make that test if it might help them. But I can say that we're working very hard at tests, and a combination of blood tests and brain imaging may give us an insight into who's at risk. But again, without a drug, it's knowledge that isn't terribly helpful at the moment.
Could you take a hypothetical example, say a person who's diagnosed and dies 6 years later of Alzheimer's, what might be a logical projection, sequence of what happens to that person?
Yes. Linda, do you want to answer that? Okay, I can do it, I suppose. It's unknown, I have to say. Each person who has Alzheimer's disease is different, and very often people have multiple problems at the same time. So for instance, they could have frontal temporal dementia a little bit. They could have vascular dementia at the same time, which is due to cardiovascular problems in the brain. And each one of those contributing factors can change their pathway. So some people, for instance, become quite agitated, even abusive, and some people are the sweetest old ladies and men you could imagine. And it's not really predictable at the beginning what's going to happen in the individual case. Sorry.
Doctor, thank you for coming today. How much do you need to raise in order to get the National Institute of Alzheimer here in Denver? Where are you, and how much federal funding is committed at this point, or how much are you trying to get our legislators to commit to? Right.
Okay, so it's a question of money and science. If the science isn't there, then of course we won't get our designation and our grant, but I'm pretty sure we have the science. The grant from the NIH would be about $1 million a year, and we would hope to duplicate that from private and public fundraising in the Denver area to essentially tell the NIH that we think it's important here, and we want a center here, and we're willing to partner with them for that.
Doctor, I'm curious what kind of time frame you have to establish that center.
Okay, so we're going to be applying to the NIH in May of this year, and it may take a couple of times to get that center designation. We hope to get it the first time. When I was in Tampa, Florida, we applied for it from the state of Florida. We got it the first time. That's very rare, but that's what our hope is. So we'll be working extremely hard in the next couple of months to get that application out. Good question, thank you. Yeah, Linda's going to come up and answer questions also, because she knows many things I don't know.